talk. So we shall now go on to our fourth speaker, Dr. Sunita CHAURASIA, who is a consultant cornea anterior segment refractive and also pediatric corneal services from LV Prasad, Hyderabad. And she is going to tell us something more on a very important topic, usefulness of specular microscopy in clinical practice. On to you, Dr. Sunita.
Yeah, thank you, madam. I'll share my screen now. Yeah, are my slides visible?
Yes, yes.
Yeah. So this topic is something which is again very important clinically, and thank you, madam, for giving this opportunity. So I'll be talking of the relevance of endothelial imaging using specular microscopy. Specular microscopy, we all know by basic principle, it depends upon the optical principle of specular reflection, which means an incident light and a reflected light passing through the area of interest, which is the corneal endothelium, and you are able to image by means of the specular reflection. This is casted as an image and is interpreted by means of the image which is procured on specular reflection. So one of the important things in interpretation is the quality of the image, which is of paramount importance in its interpretation. So we have to really see that the image what is procured is analyzable, and thereafter we should do a clinical specular correlation. There are certain abnormalities in the tear film which could be because of the abnormal tearing or unhealthy tear film, haze in the stroma, Descemet's membrane irregularities, which is namely Goutte, which is seen in Fuchs endothelial dystrophy, and pigments on the endothelium which can result in blurred images from the specular microscopy, and hence these images may not be suitable for analysis. In interpreting specular microscopy, it is also important and very relevant to know the age-related endothelial changes which happen in the endothelium with respect to the endothelial cell density and the mean cell area. We almost always talk about the ECD, but the mean cell area is something which we should be always knowing decade-wise change to interpret and make sense of the specular microscopy quantitative parameters. This is a specular microscopy of a normal 10-year-old. This is an example of a good analyzed image from the central corneal area. We can see there's a mark over here in the arrow showing the rest. So this is from the central cornea. And these quantitative parameters are reliable because the image is very good. We can make out the dark and white borders clearly. So this is a very good image which is giving a very fair analysis. And this is bound to be reproducible with very minimal test retest variability on the account that the image is good and analyzable. So few questions come with respect to specular microscopy. What is its role in Fuchs endothelial dystrophy? And can it be used to decide when to perform triple procedure versus combined surgery in a patient with FECD? So specular microscopy in Fuchs endothelial dystrophy is useful, but it should be interpreted correctly in the light of the limitations of this optical imaging system. We know that Fuchs endothelial dystrophy is characterized by Goutte, which interfere with the image capture of the endothelial cells because the extrasensors are not able to provide an imaging of the endothelium, and hence these areas are seen as dropout areas on specular microscopy. Further, additionally, what happens is that the type of Goutte characterize the procured image. In early age Fuchs, which is also called as the early onset Fuchs, the Goutte tend to be fine, confluent and numerous. And because of this nature, the image is often non-analyzable without a clinical edema in the patient's eye. So inability to image the endothelial cells in these cases did not necessarily mean the absence of endothelial cells or its function. So true nature and functionality of endothelium in cases with FECD is primarily known by the symptoms and clinical signs as we see on the slit lamp. If the specular images are reliable, then vital information can be derived from the specular images itself, and there can be certain indirect clues which are obtained from the image cells from the mid-peripheral region. We know that Fuchs is a central corneal disorder to begin with and thereafter spreads to the periphery. So the images from the mid-peripheral area also gives us an opportunity to know about the status of the eye condition. This is just to show 5 images of 5 different patients. So we see the first image which is non-analyzable. This is an early age Fuchs endothelial dystrophy where the visual acuity is 20/20. Patient did not have any complaints. He only had numerous Goutte, and because of this reason the image is non-analyzable because we are not able to procure the image. The PACI was 468 and 470 in this patient, and this patient had nil symptoms. The second image is from a patient again from the central cornea, and we can see that the ECD is 2600. The image is fairly reliable because you have intervening cells which are of normal cell area. The mean cell area is 398, which is as per the age, it was normal. And third image is again of a patient who has more numerous cuttae, but if you look at the ECD is 2400, mean cell area is 423, which is as per the normal of the age of the patient. The fourth image of another patient where the ECD is 1400, and this is from the peripheral area. The last images 4 and 5 are from the peripheral region. And here we can see that the mean cell area is 677, which is far more than twice and what is normal for that age. And the last one is certainly completely abnormal, because we can see that the mean cell area is completely out of range, which is almost like 4 times what normal should have been. All 5 images are in the same magnification. So based upon these pictures, now we see the first image, the patient did not have any clinical edema. In the second and third, obviously if a patient has cataract, patient can simply go for cataract surgery alone. In the fourth, it will be risky to just do cataract surgery alone. This patient will require a transplant. And in the fourth, obviously there's no question that the patient definitely needs a combined surgery. This is how we are going to interpret specular microscopy in Fuchs endothelial dystrophy based upon the intervening cells. Now we have another modality in Fuchs. We often think about doing a DSO, not a very standard of care, but then which cases can go for DSO versus DMEC. This is one such case which has a patch of endothelial layer and patch of abnormal area, and we can see cornea as such seems to be compact in the periphery. From the central area, we are not able to capture the images because obviously there's a sheet of abnormal Descemet's membrane. And from the peripheral area, this third image, the C image is in down gaze, and we can see a good endothelial cell density, 2301. This patient, if one wants to attempt, DSO can possibly consider in this patient. What about this patient? This is another patient who had an image looking like this one. We see far numerous guttae, and this is again from the periphery. Though the cutoff for doing DSO is 1000 cells in the periphery, these cells don't look healthy, and the cell density is 1476. But when we look at intraoperatively, as this is just a staining prior to doing the cataract surgery and DMEC, so that we can see the abnormal staining pattern on the endothelium, showing that there's a loss of the endothelial cells over here, and that is why you have the staining pattern. So this imaging, which has been captured from the peripheral area preoperatively, shows this kind of flare, but which is certainly not suitable for going for a DSO. This patient was planned for a DMEC surgery. Another reason why specular microscopy should be done is to formulate an accurate diagnosis of a clinical condition. Many endothelial disorders can be confused with Fuchs endothelial dystrophy, such as non-Fuchs pseudophakic corneal edema, pseudoexfoliation, angle closure glaucoma, chronic uveitis. Specular imaging helps in making a proper, appropriate diagnosis. This is to share one case who had a history of decreased vision since 2 months in the right eye. Both eyes have had have had cataract surgery. OD had corneal edema. The Paki in the right eye 619 and 554 in the left eye, and this was diagnosed as case of Fuchs endothelial dystrophy. OD, obviously the corneal images, the endothelial images was not procured because of corneal edema, but if you look at the left eye specular images, this is certainly not a case of Fuchs endothelial dystrophy. It is a non-Fuchs pseudophakic corneal edema, probably is the iatrogenic factors accounting for the cell decline in the other eye. So imaging from the opposite eye helps in formulating the diagnosis for this particular eye. This is another patient who had a right eye poor vision, and OD vision was 2320, left eye was 2020. He's a patient of PACG on anti-glaucoma medication. Cornea on clinical examination showed diffuse endothelial pigments of variable size, and there was peripheral focal corneal edema, again labeled as Fuchs, but then if you look at, there are dropout areas, but then if you look at the clinical specular correlation, it is not Fuchs, because these are mainly because of, these are casted as shadows as dropout areas because of the pigments on the endothelium. So many other entities have a very peculiar endothelial characteristics. One such dystrophy is a posterior polymorphous dystrophy one needs to be aware of. In this, endothelial imaging in general reveals a low endothelial cell density. Cornea may be compact, but there's a increased cell area and low endothelial cell density in these eyes. This is just to show one patient who's a 25-year-old, and both eyes are involved. One eye has a serpentine band-like pattern and dotted dots and vesicles, and the left eye shows more prominent findings of bands and vesicles. So this is the specular image captured from different parts of the eye, showing low endothelial cell density. And these are certainly not normal for a patient who is 25-year-old to have this amount of cell density and this cell area. But this is what is the peculiarity of this posterior polymorphous corneal endothelial dystrophy. Another patient of the same dystrophy, this was a 35-year-old with a unilateral involvement. The left eye is normal, But if you look at the right eye had serpentine band-like patterns like this, and this patient also had a steep cornea. Now, this is an important
You have
finding
1 minute remaining,
about
ma'am.
this condition, because many of these patients get labeled as keratoconus. So when we do the specular, we can see that there's a low cell density and the opposite is normal. Another entity is to map out the area of abnormality in IC syndrome, and this is very typically characterized by dark light reversal pattern of the corneal endothelial imaging. And this helps in knowing the abnormality, even though the cornea may look compact and vision may be good, but helps in mapping out the abnormal areas on the endothelium. Another indication, many of the patients with the grafts can develop cataract, and we may have to plan cataract surgery in these eyes. To know how suitable the eye is to undergo and tolerate the cataract surgery, one would want to do a specular microscopy in these eyes. Monitoring the health of the graft status, both PK and EK, is important to do a serial specular microscopy. Now, this is one patient who had a DSEC done 10 years ago, and this is the morphology of the eye. And this is another patient who has DSEC surgery 10 years ago. Now we can see how bad the endothelium is in the second patient versus the first eye. This patient did well, and at 11th year we can see the graft is clear, but this patient expected to have a late donor failure, and this is how he landed at the 11th year. So the serial monitoring of the endothelial in grafted eyes is really important. One more indication nowadays, many patients, because they are put on Ripasudil for IOP control, it is important to do serial specular imaging to distinguish a graft failure or a graft rejection versus donor failure in patients who are using Ripasudil. So this typically happens, the Ripasudil related epithelial edema, in patients who have got a poor endothelium. So unless we know what the pre-operative endothelial count, at least the previous visit endothelial count was, we will probably treat these patients as rejection. But to know a kind of patient who has low endothelial cell density, we know what edema could be because of. It's not possibly because of rejection, but mainly because of low endothelial cell density. And Ripasudil helps kind of manifest the epithelial edema in such eyes. The relevance of specular microscopy in eye banks is very important. We know that it is a very important tool in the eye bank to assess the donor cornea allocation for various surgeries. And these are the ECD guidelines which we follow for donor cornea selection. Thank you for your patient listening. If there are any questions, I'll be happy to answer them.
Yes, that was a wonderful talk, Dr. Sunita. Question to you or Dr. Merle is something very simple for a comprehensive ophthalmologist. Like, when would you do specular microscopy in a lamellar corneal surgery, and if there is an interface haze, which could also impact the quality of assessment? So would you tell us that whether you should do a central approach or a paracentral approach, or which location would you look for?
So is Dr. Merle there?
Yes.
So, primarily we want to know the central corneal endothelial density in most indications, but in FECD it becomes more relevant because of the nature of the condition is such that it affects the central cornea first and then the peripheral cornea. So we gather some information by imaging the peripheral cornea. But in general, for the lamellar surgeries, we would want to know what is the central endothelial cell density, because that gives the best idea, and free from aberrations also, because when you image the peripheral cornea, you also get some curvature related issues, and that could also impact your cell density. So for consistency of follow-up of the patients, it is important to view these specular images right from the central part of the cornea.
Thank you. Dr. Rajesh?
I think it's a very well covered presentation. The only thing about the comprehensive ophthalmologist is that whenever you are planning a complex cataract surgery, it's always advisable to get a pre-op specular done and have an idea of what the cell count is like. So, if you have post-operative corneal edema, you will be able to then determine, whether it was because of low endothelial cell count or it is something related to the surgery which can recover in 4 to 8 weeks.
I think, Chitra, this was one of the most interesting talks on a subject like specular microscopy, which can be really boring.
True.
But it was made so well by because with all the examples and all the case presentations, that it has taken a different, dimension.
Yes.
So, talk, Sunita.
Yeah, in fact, it's been an invaluable talk. I was amazed how such a dreary topic as that could have been made so good.